Welcome, ladies and gentlemen. Really pleased to be with you here. This is the first event I attend for the BRC, and the theme, the surgical theme for the Biomedical Research Centre is a new theme which was added in the new bid that was submitted to NIHR, which was, as you know, very successful. So we're delighted for the surgical community to join the NIHR BRC as a new theme. So I'm going to talk to you about one of my favorite topics, and I owe a lot to the BRC for helping us to realize this development at Oxford. And I arrived in Oxford in October 2008, and at the time the first BRC had already started. And when I came, I said that, you know, Oxford needed to, in certain areas, to move into the 21st century as opposed to staying in the 19th century. And one of these areas was to develop more of the keyhole surgical procedures, particularly for urological disease. And Oxford was receptive, but in particular BRC, who contributed substantially to make this happen. So I'm really grateful. And I think I have to start by saying that robots in surgery is a complete misnomer, because there is no such thing as robotic surgeons, and there's no such thing as robotic operations. Everything is still controlled by the surgeon. So when you think about robots, you have to think of it as an instrument which is controlled entirely by the surgeon, the skills and the knowledge of the surgeon himself or herself. So Jenny told you who I am. I am a surgeon, and this is what I do half of the week, is I check patients' prostates and bladders and other things. I don't always like it. I also operate during that half of the week, sometimes with difficulties. As you can see here, my trousers had just dropped down, and it was quickly snapshot by one of the nurses, so I'm very proud of this photograph. And the rest of the time, I try to think about why I'm doing what I'm doing. And if you haven't recognized me, I'm on the right-hand side of the picture. So that's my life. And I just want to take you through a journey. And the journey is that surgery started centuries and centuries ago. And I'll remind you that surgeons used to be non-medically qualified barbers. And it's the very reason why when you qualify as a medical student now, you become a doctor, but when you qualify as a surgeon, you become a Mister. And it's the only country in the world where surgeons are called Mister. And it reflects the fact that surgeons were barbers and not medically qualified in the past. And if you've watched the movie The Sweeney, you'll quite realize what that means. But we've moved on since, and open surgery has lasted for centuries. It's still very much the mainstay of how we do our operations. You have to remember that about 30–35% of patients will get exposed to a surgical specialty, and that more than 50% of cancers are cured by surgery before radiotherapy and certainly before chemotherapy. So surgery is still very much a most important part of the armamentarium to cure and to treat patients. And I hope you're not squeamish, but I'm going to show you here an interesting video clip. On the left-hand side is an operation to remove a kidney, which was filmed 100 years ago. And on the right-hand side is the same operation filmed in contemporary times. So I hope the technology doesn't fail me, but it is self-explanatory. So you can see the difference between the right and the left-hand side. All the technology on the right-hand side, the sterility on the left-hand side, 100 years ago, no gloves, no masks, no sterility, big incision, hands inside, and suddenly the kidney will appear. Whilst on the right-hand side, you see the precision, the imaging, and you know, the difference it makes. So please forgive me for that, but it gives you an idea of the evolution of surgery over the past 100 years. There's the kidney coming out on the left-hand side. On the right-hand side, everything is targeted. It's also the kidney. And that's it, big clamp across. And out comes the kidney with a big suture around it. And you can see all the electronic information about the patient appearing on the right-hand side. So the contrast is absolutely enormous. And surgery hasn't stopped to evolve. It's not just moving to keyhole surgery, but it's moving even to different types of keyhole surgery. Now, I will talk to you again about my favorite organ, which is the prostate. So for those of you who are not familiar with the prostate, it is a male sexual gland. It's located below the bladder. This is the bladder, urinary bladder. This is the back passage, and this is where the prostate lies. The function of the prostate is that it's a fertility organ. It secretes fluids, which added to the sperm, makes the sperm viable and allows its mobility. So it is a fertility organ in youth and in old age. It makes us a living as urologists because as one ages, the prostate will get enlarged, will not necessarily become cancerous, but will become enlarged and will cause problems. So what is prostate cancer? Prostate cancer is like any other cancer. It's cells which decide to grow outside the conventional rules of growth and proliferation. And the main characteristics of prostate cancer is that it is the most frequent cancer in men in the Western world. It doesn't give any symptoms until it gets to a very advanced stages. And the only way to find out about it early is to do a simple blood test. And then biopsies of the prostate. But even that is not particularly precise. So there are lots of shortfalls because many of the cancers that we find are trivial cancers which will never grow to become serious enough to kill the patient. So the majority of these cancers, if they're found, there's a tendency for them to be overtreated. When cancer of the prostate spreads, it goes to the lymph nodes and it goes to the bones. Prostate cancer cells have a particular affinity to bones. So again, this is the problem with prostate cancer. So this is particularly for gentlemen in the audience. If you're able to read this sentence, you don't need to worry about it. And this is not a mistake because I prepare my slides myself. But if you can't read it, then perhaps you should worry about prostate cancer. So let's see what that sentence says. And this sentence was written by a physician over 150 years ago, and this is what he says: as the eyes grow dim, the trunk bends, the cartilages ossify, and the arteries change in their coats, so the prostate is supposed to grow large and hard. And what it means is that prostate cancer is very common and it's part of the aging process almost, but it will not necessarily kill the patients. And this is the real dilemma. If you look at these graphs, what you can see is two bars, two horizontal types of bars, a light blue and a dark blue. The light blue is the number of cancers diagnosed, and the dark blue is the number of men dying of prostate cancer. And whilst in the third world, the numbers are more or less equal, as you move west and as you cross the Atlantic, there's a huge discrepancy between the number who are diagnosed and the number who actually die of the disease. And what's happened is over the last 20 years, there's a new test called PSA which has emerged. There's the ability to do biopsies. And a huge backlog of cancers which are not significant have been diagnosed. And because they've been diagnosed, because they've been called cancer, they've also been treated. So the two words which have emerged over the past 5 to 10 years is the word overdiagnosis, which means we diagnose too many of these cancers, and overtreatment, which means we overtreat too many of these cancers. The difficulty is we can't always discriminate between the cancers which will progress and be harmful to the patients and other cancers which will not. So we also undertreat some cancers. And it's a very difficult dilemma where there's a lot of research which is ongoing, including ourselves. Prostate cancer hits anyone. And you can see here a selection of very famous people who developed prostate cancer over the years, and no need to name them, they're famous enough for you to recognize them. So it doesn't spare anyone. And if we think of the ideal treatment for any condition, what does that mean? Well, it's a treatment that cures everybody, that is given as an outpatient, that has no side effects, and it costs nothing. Of course, this is the dream for the NHS, for the trust. And like the ideal husband or ideal wife, the ideal treatment does not exist for any condition. So in the 1990s, the conventional treatment option for prostate cancer, which was early enough in fit men, was to remove it. And it was to remove it through quite a substantial incision, which went from the belly button down to the bone here. And the operation took 2 to 3 hours, and recovery of continence, so for patients not to leak, could be 3 to 6 months, could be longer, and sexual function and erections were usually affected. So radical prostatectomy was the curative surgical gold standard. Radiotherapy, which is X-ray treatment, were largely given to men that did not whet the appetite of the surgeons. So they were a little bit older, they weren't very fit, and the surgeons didn't want to spoil their outcomes and their results. So they sent these patients to the radiotherapist who would give them X-ray treatment. The results wouldn't necessarily be terribly good, and then surgery would always be on top. Now, I'm exaggerating a little bit, but these were the kinds of attitudes at the time. And there was a term called watchful waiting, and when I was training, I did live through these times. So you had patients presenting with cancer, and you told them, don't worry, the cancer is not going to do anything to you. Gave them a tap on the shoulder and you send them away. And that was watchful waiting. It's largely for men with a life expectancy less than 10 years and with a lot of other medical problems. Now, it's perfectly reasonable to continue to do that if men present with a cancer which doesn't seem to be harmful in their 70s and 80s, where we know that the cancer is not going to catch up with them, it's not going to cause them harm, so it is best to leave them alone. But what watchful waiting has become now is what we call active surveillance or active monitoring, which is actually not allowing the cancer to become very advanced, but to monitor it carefully until it becomes serious and then to offer treatment. So in the absence of all this uncertainty about the benefits of treating these patients with very small cancers, what is it that made us be able to take a patient with a small cancer and put him on the operating table and to say, you need an operation? And I've searched this for a long time and I found the answer, which is called the surgical imperative. And what the surgical imperative tells you is this: if a surgeon tells you that without an operation you will die, as a result of an operation you may die, you have no choice but to have an operation. And this is how we've been advising our patients. What's very interesting is to find out who has actually made that quote. And it is absolutely true. And then we say we do these operations, these interventions, because we save patients' lives. And then I ask myself, well, what's the meaning of life on earth? And this is not philosophy. And I found the best definition of it is this: it's a sexually transmitted condition with 100% mortality. Even if you cure prostate cancer, we're still going to die. We can't stop that. So it's all about interpretation. And then we started to say, well, actually, by operating and removing the prostate, this is, by the way, a prostate which has been carefully removed, we improve the patient's quality of life. No, we improve quality of life. And the question that no one asked is whether quality of life is better for the patient or for the surgeon. And I think this is still an interesting point. We're also very proud of doing these kinds of operations because they are delicate. And what's important is not just what we remove. You know, we have to remove the cancer completely, but we also have to leave behind the structures which will keep the patient fully continent without leaking any urine after the surgery, and being able to resume sexual function and erections and have intercourse. So we're very proud of doing this operation. The patients improve very quickly, but there are some things in life that you should not believe, and one of them is when surgeons tell you we have no complications, because complications do happen. Now, what's interesting is to see here the number of radical prostatectomies performed of the year in the UK. The operation was refined in the US in the 80s, and in 1991 there was only one surgeon in the UK in London who was doing open radical prostatectomies, and that year he did 36 cases. And very slowly it took off, and now in 2012 we are probably doing around 7,000 of these procedures in the UK. And we're still conservative. For the same population in France, they're doing 25,000 radical prostatectomies. So we're still very conservative in the UK compared with them, and our mortality is no different. So one of us has got it right, and I don't think it's the French, despite some of my background, but there we are. So how could we answer these questions? So we've designed back in 1997, 1998, what now has become the largest randomized controlled trial of surgery versus X-ray treatment versus observation in men who are detected through a simple PSA test. It's become the largest randomized controlled trial worldwide. It's been happening in 9 centres across the UK, very generously funded. It's NIHR's most expensive clinical trial. They've committed to date £34 million just for that trial, and I've been very privileged to be the chief investigator. And this is what we've done when we've closed recruitment, which took over 10 years. We had tested 111,000 men. We diagnosed around 3,000 cancer, of which 2,600 were eligible, and of those 2/3 agreed to be randomized to either active monitoring, surgery or radiotherapy. And we're awaiting the results. Because prostate cancer grows so slowly, we will have the results by 2015, 2016, and it's going to be a major impact on how prostate cancer is managed worldwide. So we're very excited by that. In the meantime, what we have to do is we can't stop the diagnosis of prostate cancer. We can't stop men from coming forward with a PSA which has been done by the GP, sometimes without even any counselling. The number of men that we see who go to Well-Men Clinic who have a PSA test, they've not even been told they were having a PSA test. Then the GP sees them and said, oh, by the way, your PSA test is elevated. I'm going to send you to the urologist. Why? Because you may have prostate cancer. Oh, but I didn't know about that. And the recommendations from the NHS are very clear. I'm a member of the NHS Risk Management Group for prostate cancer, and we say that all men need to have access to a PSA test, but they need to be counselled before the test is done. And it's not done well at all in the community. So we will always continue to have an element of diagnosis of prostate cancer. And it is our responsibility to improve the risks of treatment. And today I'm just going to talk to you about surgery. And the risks of surgery are risks of death. It's small, but it's there. Risks of bleeding, it is small, but it's there. The length of stay conventionally has been 5 to 8 days for an open procedure. The risks of leakage, urinary leakage, which is quite devastating for socially, and lack of ejaculation and erectile impotence, which can ruin sexual relationships, which can ruin couples. So these are very, very important responsibilities, and ethically we are bound to improve this until we get some evidence as to who to treat, when to treat, and by what means. So in the 1990s, because the French were doing a lot of radical prostatectomies, they invented keyhole laparoscopic radical prostatectomy. They developed the technique. The Americans tried on dogs and they failed. They tried on patients and it didn't work. And the French developed the technique in 1990 very, very quietly, and then they published a series of 400 patients they'd done with reasonable results. So the technique took off in Europe, and this is conventional manual keyhole surgery. And this is how it happened. Essentially, instead of making a big incision in the middle, you made little holes and you introduced instruments, and you started to do the conventional dissection using these instruments. The cameras could fit into the small keyhole incisions. There was better visualization than open surgery because you had magnification. But the drawback is if you, I don't know, when you go to have a Chinese meal, whether you use the chopsticks or the knife and fork. But imagine that you've never used chopsticks and that you decide to eat your chow mein with chopsticks. And you'll know exactly what I'm talking about. Doing keyhole surgery when you start is like using Chinese chopsticks inside a patient to remove an organ. So it's not a trivial exercise. And very quickly, well, when I say quickly, probably over a few years, people realized that there were limitations. Keyhole was good, but it had limitations. And these are some of the limitations. First of all, the vision that you had was a vision on a 2D screen of what is essentially a 3D organ. So you had to build in your own brain the conformity of the organ, but you only had a two-dimensional image. And you will know the difference if you ever come across 3D screens, television screens, and you can see what the difference is. Dexterity, the learning curve was very, very steep. And some recent publications suggested that you could continue to improve after doing 700 of these procedures. So there's a steep learning curve. Long, awkward instruments, remember, chopsticks. Counterintuitive movement. So when you want to move the instrument to the right, you had to move your hand to the left. And this is, you have to get used to that. The ergonomics were not very good, so the position of the surgeon, and as I say, you needed many, many patients to be able to improve even with training. And in the 1990s, what happened in parallel, completely fortuitously, is that NASA was developing a prototype for robot-assisted surgery. And it was developed for surgeons to be able, for military surgeons to be able to operate on soldiers who were exposed to radiation to protect the surgeon. So they developed this prototype of not having direct contact with the patient, but to be remote from him with instruments, laparoscopic instruments inside the patient, trying to operate. And they developed this prototype, which was then bought by two companies, one in Europe and one in the US. The two companies eventually merged into a company now called Intuitive, which is based in the US, and they produce what is now known as the Vinci robotic system from Intuitive, which is going into its 4th generation. So the concept is that it is even less invasive than manual keyhole surgery. It's supposed to give better outcomes. It is an alternative to manual laparoscopic prostatectomy. It challenges other less invasive procedures, and it has a very multi-user potential, like gynecology, pediatrics, cardiac surgery, although David Taggart, our professor of heart surgery, cardiac surgery, tells me that robots will remain for the future for heart surgery, and abdominal surgery. But for the pelvis, I think the case has been pretty much made. So as I told you in the beginning of my talk, we were very fortunate to get a lot of support from a number of benefactors, including the Biomedical Research Center, NIHR, the ORH Charitable Funds, the Allison Foundation, local charities like UCare, the Cancer Benefactors, Medical Research Funds, and the John Fell Fund. All together, we produced a very decent capital, and within 3 months from me arriving in Oxford, I was delighted with the outcome of this fundraising, and we were able to purchase and to acquire the top-of-the-range model with 2 consoles, as you can see here. So the principle is that the instruments that you have seen, and I'll show you, are attached to the patient. The surgeon sits on this PlayStation, we can call it, and another surgeon can sit on the other PlayStation, and you can control the instrument remotely with the patient 5 meters away from you. So if you're very good with computer games, there's no problem. This is the difference between conventional keyhole instruments and the robotic instruments. With keyhole instruments, if you imagine a chopstick, you can go up and down, right or left. That's all you can do. You can't rotate. And when you rotate, you have to change the movement of your hand. With robotic instruments, you can have 360 degree, which mimics exactly the movements of your fingers and your hands. And you can see here the difference between the two, where on the right hand side is the movement of the conventional laparoscopic instruments on the right hand side, on the left hand side is the robot, and you can see the versatility of movements. The vision system also is spectacular because as opposed to 2 dimensions, it's 3 dimensions. So it's as if you have your head inside the patient and you can see in 3 dimensions, and you have a magnification of 10 to 15 times. It's produced by 2 cameras simultaneously in the same scope. So this is a robotic equipment which is set up prior to procedure. What you have is the 2 consoles, and you have a stacking station, and you have lots of screens everywhere so that everyone can see what is happening, and in particular the assistant and the nursing staff. So it's a real team effort. It's not a single surgeon procedure. And you can see all the instruments being draped very carefully so that they are sterile, and the very, very limited number of instruments that we used here, which are simply on that table. And you can see, essentially, we use 3 instruments only. And here, yeah, okay, so what you can see, this is a model, this is not a patient, and you can see how the hands manipulate the instrument on the PlayStation and how this translates into movement, suturing what's supposed to be skin, but this is a model with the needle going in and out in a very, very precise way. And all you have to do is you're moving 2 fingers using this joystick, equivalent to a joystick. So one of the biggest challenges when you do a radical prostatectomy is to try and preserve sexual function. You try and preserve sexual function by dissecting very carefully a bundle of nerves which are attached to the prostate. And you can see that here it's in yellow. And with the instruments, you separate very carefully the prostate from these nerves in order to protect them so that the electric wires which are responsible for erections are protected. And you can see here in real life, so you can see this is the robot working with the hands controlling it, separating very, very gently. And we're talking about millimeters here. And you can see the precision of the movement and the precision of the instrument separating the prostate from the nerves. Okay, and all the bleeding is well controlled with little plastic clips. And you can see how the nerves are being really protected here without compromising the surgery of the cancer itself. So that's the advantages: the vision, the precision, the control. And one thing which is really clever is that even if you've had 2 or 3 drinks the night before and you have a slight tremor in the morning, the computer actually removes your tremor. So this has been a real advantage. Advantages to the patient, at the moment similar cancer results, although I believe that with time we're going to show an improvement in getting better results, faster return to continence. I was just discussing with one of you that the speed of recovery after robotic surgery for prostate is quite remarkable compared with open, with patients regaining continence within days, if not straight away. Sexual function coming back also very quickly. So I've seen this morning a patient who's 70 years old who had surgery 6 weeks ago and he's now getting erections and all his cancer has been removed. So it is making a difference. These are the kind of outcomes which we were not seeing with open surgery before. Less complications, less pain, shorter hospital stay, 36 hours or less, fewer major complications, and obviously less scarring. So far since August 2009, we've done here 125 cases. The average time on the console or PlayStation is 3 hours. The average stay is 2 days. Positive margins. I was delighted to see that kind of figure for organ-confined disease. It's approximately 7%, which is comparable to the best figures in the US and in Europe. Very good continence and recovery of erectile function. We've never had to transfuse a patient, which is quite remarkable. We've not had any serious leaks. We've not had major complications so far. No conversions to open cases. There's 2 of us now who are able to do this surgery. 2 other surgeons are in training. We've now moved on to kidneys, so we're doing kidneys and partial removal of the kidneys also using the robot. We're going to move to bladders, and our colorectal surgical colleagues have started to do some colorectal lower GI operations using the robot. We also have now a teaching course module as part of our master's degree in surgery. The next challenge is about evaluating things, because the biggest plague we have, the biggest problem is that the NHS is not reimbursing us with the cost. So every time we do this on the NHS, it is a cost pressure on us, and we have to revert that so that the primary care, the commissioners start to pay us the full cost for it. We are recovering some of the costs in different ways, but not as part of the tariff. These are the questions we need to ask. Is robotic surgery a good development, or is it driven by technology freaks? Well, I think I know the answer. Is robotic surgery better for patients with improved outcomes, reduced morbidity, reduced hospital stay? I think all these data are accumulating and are favourable. Is robotic assisted surgery better for the surgeon? Does it make a difficult operation easier? What is the learning curve, training issues? And all this is being worked out, but they are important and challenging questions. Can we improve robotic surgery? And we have some very exciting research also funded through the BRC, which is addressing these issues. So we don't have tactile sensation. Can we recover that? Can we have pressure-sensitive pads? Can we have better real-time imaging and edge definition of the gland? And we have a very exciting project where we're using antibodies which are tagged with a fluorescent dye. And when injected into the patient, it shines only where prostate cells are. So what we're going to try and start to do is, once we separate the nerves from the gland, we're going to be able to shine the light and to be able to see whether we've left cancer cells on the other side of the dissection, and then remove them to make sure that we have an adequate excision of all the cancer without leaving cancer cells behind. It's going to affect the cancer outcome dramatically if we're able to do that, and it's very exciting. So image guidance is going to be very important. Interaction with tissue is going to be also important. Networking, and it has been done between different centers, different consoles, different surgeons working together. Training is being revolutionized, and obviously advanced instrumentation. And this is the Da Vinci Connect network. It has been done from across the Atlantic, where 2 surgeons have worked together on the same patient from 2 different consoles. With the power of IT, all this is going to be possible. My master plan is to eventually become very rich, buy myself a house in the south of France, and then get my console down and operate from there without having to be here. That's my master plan. I don't really think. Maybe BRC could help with that. We'll see. Single port surgery is coming along, where instead of making 5 or 6 little holes, you make a single hole with lots of little instruments coming out from the same hole to avoid multiple keyholes. So the take-home message is really that robot-assisted laparoscopic prostatectomy and other procedures are the present, they're not the future. It provides, at the moment, the evidence for less pain, shorter hospital stay, better precision, vision and control. At the moment, similar cancer outcomes, but I think that will change. There are cost issues, and there are lack of clinical trials to provide high-level evidence for wide adoption in the NHS. Is it going to replace the surgical hand? Absolutely not. The robot will not make a bad surgeon a good one, but it will make a good surgeon do a better job. And I think this is an important message for you to take away. And finally, this is our Surgical Innovation Evaluation theme, which is supported by the Biomedical Research Centre, and it's in 3 sub-themes: ablative devices, including robotic surgery, high-intensity focused ultrasound, different forms of energy, device-targeted therapies to be able to target tumours and other benign tissue that need ablation better, and organ reconditioning, which is improving the outcomes of transplantation. And what's even more exciting is that all this is underpinned by a platform that we are creating, which is a combination of technology labs with new ideas, proof of concept of these ideas, taking them to first in man, and then developing early phase trials onto late phase trials using our new surgical intervention trials unit, all underpinned by imaging and biomarkers. So thank you for listening, and I'll take any questions.